Good morning, everyone. Please excuse our delay. We are having a few technical difficulties. Imagine that. Oh my gosh. Happy day after Mother's Day to everyone. We all have mothers, and I hope it was a special day to remember them. And my name is Mary Pratt. I work here at CMS. I'm a division director for the Division of Chronic and Post-Acute Care. We live in the Center for Clinical Standards and Quality in the Quality Measurement and Health Assessment Group. We're a small but mighty group of mostly clinicians, health services researchers, physician, a real interdisciplinary team of people that are working on a number of the post-acute care quality reporting programs that CMS has enacted as a result of the Affordable Care Act. One of them being the Inpatient Rehabilitation Facility Quality Reporting Program that brought you all here. And we have a full day. So just briefly, the purpose and goals of the training are to understand the requirements for the IRF Quality Reporting Program, to accurately code the IRF PI, version 1.2, for the quality indicator items, which is the pressure ulcer and the influenza vaccine items, and to accurately submit the IRF healthcare personnel influenza vaccination coverage data into CDC's National Healthcare Safety Network. We have a full day, a full agenda. Hopefully these 5 minutes won't delay too much our plans. We've got a number of items that you can see here on the agenda, everything from the pressure ulcer staging to discussion of the all-caused unplanned readmission measure for 30 days post-discharge from inpatient rehab facilities. It's a claims-based measure. There are a number of resources. We always have resources and websites, and if you've participated on our open door forum calls, you hear people going on and on and on how to send an email to someone. Here it is in writing and hot links, so if people need to get a hold of us, this is how a number of areas where you can do that, as well as signing up for a listserv so that you get notices and announcements of upcoming future trainings. Now, if there are going to be questions today throughout the day, we're asking that the attendees please, that are in the room, to please submit written questions to the staff here, and we'll have note cards, I believe, for people to use to submit them. And then for participants online, there is an email address at irf.questions@cms.hhs.gov. So welcome again, and we look forward to a full day. I think I'm turning the podium over to Charles Paget, and he'll walk you through the next series of items.
Thank you very much, Mary. I really appreciate it. I'm going to be doing an overview presentation, but before I do that, I just have a few announcements to make, some directions for the day, if you will. I'm going to ask that everybody please turn off all your cell phones, and if you need to take a call for some reason, we're going to ask that you step out in the hallway so as not to disturb any of our presenters or our guests. The doors in the hallway and pre-function area outside the auditorium are off limits and are for emergency only. So this glass wall has several doors along it, right outside the auditorium, and an emergency alarm will sound if you use those doors. So if you need to exit the building for any reason, you need to go back to the main lobby and go out the front exit. Excuse me. You must wear your visitor badge at all time, and you're only allowed to go to the cafeteria There are restrooms right along the side here, restrooms down in the cafeteria. There's also a coffee stand downstairs. We will show everybody where that is during a break, so you're aware of all of that. If you need something in the meantime, one of us will be over here and we can certainly direct you. We won't make you wait until a break. In a case of emergency, we're going to ask you to please follow the directions. Please follow my directions for exiting the building. We will escort you out of the building ourselves. We ask that you don't leave any packages, briefcase, duffel bags, etc., unattended. Security will come in the building will be evacuated for precautionary measures for any bags that are left unattended in the building. So just kind of think of it like an airport, I suppose, and we'll all be okay. Lunch is available in the cafeteria. We're going to ask if you lose your direction in getting back to the auditorium after lunch, you can ask any CMS employee. They'd be more than happy to point you in this direction, or you can ask one of the security guards that's available up front. You may not go out of the building to eat lunch, and the reason for that is there are several security procedures to get back into the building and get back on campus if you leave campus to try and go eat. So we're going to ask that you remain here and use our cafeteria downstairs. Again, there's also a coffee stand downstairs with snacks available at that stand. Really appreciate that. The entrance and the exit from the building for visitors can only be made through the central office lobby. No photos are allowed to be taken inside or outside of the CMS complex. If you attempt to take a photo, you risk the possibility of your phone being confiscated. I hate to have that happen, so appreciate it if you would abide by that. We will have scheduled breaks. One in the morning, we're going to have a lunch break, and then we're going to have one in the afternoon. For you to use the facilities or buy a drink downstairs. If you need to do that on your own, please feel free to step out at any time. Again, we're not responsible for any stolen articles. We ask that you keep your belongings with you at all times. And there are Wi-Fi instructions up here should anyone need to log on. I know we're having a little difficulty ourselves logging on this morning, but we hope to get that straightened out very shortly. Okay, so with that, I'm going to move on to kind of an overview presentation. I'm going to do the first half of the presentation, and then one of my colleagues, Ann Deutsch, is going to join me up here, and she's going to review some of the timelines related to the IRF Quality Reporting Program. And again, I'd just like to welcome everybody that's in person or is streaming this via the web. Really happy to have you here. We're excited to be able to give this training, and we will move forward. Excuse me. So I'm going to go over a little just bit of the history of the IRF Quality Reporting Program, kind of where we've been and then where we are. We'll come after that, and then kind of where we're headed. Section 3004 of the Affordable Care Act requires that inpatient facilities submit quality measure data in the time, form, and manner required by the Secretary of Health and Human Services. Any IRF that does not submit the required quality measure data will receive a 2 percentage point reduction to their annual payment update for the applicable payment year. And for IRFs, I believe that's actually called the annual increase factor. In fiscal year 2012, in the IRF PPS final rule, CMS adopted 2 quality measures affecting the fiscal year 2014 APU. The first of which was the catheter-associated urinary tract infection, or CAUTI, rate per 1,000 urinary catheter days for intensive care unit patients, which is NQF number 0138. And we also adopted the percent of patients or residents with pressure ulcers that are new or worsened, short stay measure. And there is a link at the bottom of page 4 of this presentation to the fiscal year 2012 final rule where you'll find that information. This is the IRF requirements for the fiscal year 2014 payment determination. The first IRF QRP data collection period began on October 1st of 2012 and continued through December 31st of 2012. Again, IRFs were required to submit their data for the first reporting period by no later than May 15th, 2013. So that's 135 days past the end of that quarter 4 of 2012. Data collection during the first IRF QRP reporting period affected the fiscal year 2014 APU for any IRF that did not meet the reporting requirements. The 2013 IRF QRP final rule was published within the calendar year 2013 hospital outpatient prospective payment system, ACS final rule, on November 15th of 2013. And the reason for this is that during that particular year, the IRF PPS payment update notice was issued for fiscal year 2013, and it was just an update notice and not an official rule. So we submitted our rule as a rider on the outpatient rule. The 2013 IRF final rule affects the fiscal year 2015 annual increase factor determination for IRFs. The data collection period related to the fiscal year 2015 APU is, or was, I should say, January 1st of 2013 through December 31st of 2013. And at the bottom of page 6 here, there is also a link to the fiscal year 2013 rule. In the 2013 IRF final rule, CMS established a policy in which measures that have been finalized for use in the IRF quality reporting program will remain in effect and continue from year to year unless retired, removed, or suspended. And this means that IRFs are required to continue reporting data for the CAUTI and pressure ulcer measure and any newly added quality measures on a continuing basis unless CMS retires, removes, or suspends those measures. In the 2013 IRF final rule, CMS finalized a policy regarding when the rulemaking process is required to adopt changes made to existing IRF QRP measures through the NQF. So when measures go through review at NQF, sometimes changes are made to those measures, and this is our policy on how we go about handling those changes. So the use of sub-regulatory process, or we use a sub-regulatory process if the NQF changes are non-substantial, and we use a formal rulemaking process if we consider the NQF changes to be substantial in nature. And determinations of substantive versus non-substantive changes will be made on a case-by-case basis and through further rulemaking. Also, in the fiscal year 2013 final rule, we do give a few examples of each of those. Again, in the fiscal year 2013 final rule, it was necessary for CMS to adopt a revised version of the previously finalized CAUTI measure for the following reasons. It was updated by the CDC, which is the measure steward of that measure, through the NQF measure maintenance process. The CDC requested expansion of the CAUTI measure, which was endorsed to include both the IRF and the LTEC setting. And because of that, the CAUTI measure was retitled as NHSN catheter-associated urinary tract infection, or CAUTI outcome measure, which reflects the expansion of that measure to the post-acute care settings. In the 2013 IRF final rule, CMS adopted a non-risk adjusted version of the percent of residents or patients with pressure ulcers that are new or worsened, because the current IRF PI version did not include some of the risk adjustment items for this particular measure. So the non-risk adjusted version collects numerator and denominator data only, and data collected for the non-risk adjusted version will not be publicly reported, we guarantee that. And the use of non-risk adjusted measure was to continue until the IRF PI could be revised to include the necessary risk adjustment items. Which brings us to the fiscal year 2014 IRF PPS final rule. And in this rule, we adopted the NQF endorsed or risk adjusted version of the pressure ulcer measure. And that measure, the risk-adjusted version, IRFs will begin collecting that measure on October 1st of 2014. We finalized a new version of the IRF PI, which is version 1.2, and that version will be effective October 1st, 2014, and it contains the revised pressure ulcer items and risk adjustment covariates, which are used for calculating the pressure ulcer quality measure. We also established a quarterly data submission deadlines for the quality indicator items in the IRF PI. Each quarterly data submission deadline occurs 4.5 months, or 135 days after the end of each quarter. We require that IRF submit quality data for each quarter by the quarterly data submission deadline. And data submitted after the quarterly data submission deadline will not be accepted for IRF QRP compliance determinations. And missing one or more of these deadlines can lead to finding of noncompliance. So I know that the IRF PI does have its own submission deadline related to payment. This is separate from that. And what it allows you to do is it gives you 135 days, not only during which you can submit quality data to CMS, but you could go back and correct that quality data should you find there's a mistake. And as long as you do that before the associated quarterly deadline, it will be accepted in our when we're looking at it and making compliance determinations. The final data submission deadlines for calendar year measures, or calendar year or NHSN based measures, which are the CDC measures, beginning on January 1st, 2013 and continuing. So quarter one, which was January 1st to March 31st of 2013, that first was August 15th of 2013 was the quarterly deadline for quarter one of 2013. But we did extend that because of some technical problems. So you see here in quarter one under the data submission deadline that it was August 23rd, 2013. And then for every following year, of course, it would be quarter one, the associated quarterly deadline would be August 15th of that year. For quarter two, which was April 1st through June 30th, 2013, the associated quarterly deadline for submission of data during that time was November 15th, 2013. And after that would continue as November 15th of every year for quarter two data. Quarter three, which was July 1st through September 30th of 2013, had a deadline of February 15th, 2014 for submission of data. And quarter four, which is October 1st, 2013 through December 31st, 2013, had a final deadline, or has a final deadline, I should say, of May 15th, 2014, which is just a couple days away here. Final data submissions for IRF PI-based measures from January 1st, 2013 through September 30th, 2014 only. The reason I'm going over this is because this is using one version of the IRF PI. Quarter one, again, of 2013 had a deadline of August 15th. Quarter two of 2013 had a deadline of November 15th. Quarter three had a deadline of February 15th, 2014. And quarter four will have a deadline of May 15th coming up. So now I'm going to invite my colleague Ann Deutsch up here. And she's going to continue this presentation and review the rest of the timelines.
Just advance.
Yep, you just hit forward.
Okay.
And there's a pointer if you want.
This one. Great. Okay. All right. So as far as the materials here, this is again only until September 30th, 2014, when the new IRF PI takes effect. So starting October 1, 2014, you'll notice that the quarters are set up that the first quarter is October 1 to December 31st of 2014, and then each year after that, it will follow that fiscal year of October 1 to December 31st. The submission deadline for the data collected during that time period is May 15th, 2015, and then May 15th every year after that. For quarter two, it'll start January 1st, 2015, and through March 31st, 2015, and the due date will be August 15th, 2015. Every year after that, quarter two will be the January 1 to March 31st, and again, the August 15th deadline for subsequent years. For quarter three,
The time frame for data collection is April 1st, 2015 through June 30th, 2015. And the deadline for that data submission is November 15th, 2015. Subsequent years, it'll again follow the April 1st to June 30th, and then the submission for November 15th each year. For quarter 4, that'll be July 1st through September 30th, 2015, with the deadline of February 15th, 2016. And then the subsequent years, it'll be July 1st through September 30th of each year, with due dates of February 15th, the next calendar year. And again, the reason that this is different is that the IRF is tied to the fiscal year because of the payment system, and so that's why it is on a fiscal year. For the other quarterly deadlines, submission schedules for both the CDC measures as well as the IRF measures, we wanted to highlight that January 1st to March 31st of each year, the quarterly deadline is August 15th of each year, and that would be quarter 1 for the CDC measures, but quarter 2 for the IRF. So even though the time frame basically has a different quarter of impact going forward, starting October 1, 2014. So the time period, April 1 to June 30th of each year, the due date is November 15th, but again, that would be quarter 2 for the CDC data and quarter 3 for the IRF data. The July 1st to September 30th time frame for each year, the deadline is February 15th of each year, but again, that's quarter 3 for the CDC measures and quarter 4 for the IRF measures. Finally, October 1 to December 31st of each year, that will have the May 15th deadline. That would be quarter 4 for the CDC measures, but it's the first quarter of the IRF-based measures. In fiscal year 2014, in the PPS rules, CMS adopted the NQF endorsed measure, which is risk adjusted for the % of residents or patients with pressure ulcers that are new or worsened. That is the NQF measure 0678. Use of this measure will begin October 1, 2014, and will affect fiscal year 2017 APU determination. Data for this measure will be collected with the revised pressure ulcer data on the IRF. And later today, you'll be hearing Elizabeth Aiello, who is a pressure ulcer expert, talking about the pressure ulcer staging. And then Caroline Gallagher from CMS will be presenting information about coding the IRF. So there's a lot more information coming up today about this measure in particular. The data for this measure are collected with, again, the revised pressure ulcer items, and the data will be collected on a fiscal year basis, and that's the material that I just finished presenting. In fiscal year 2014, in the final rule that was put out, CMS finalized 2 additional new measures for youth in the inpatient rehab facility quality reporting program. The first one being the % of residents or patients who were assessed and appropriately given the seasonal influenza vaccine for short stay. That is the NQF measure 0680. And the reason that it says residents or patients is that this measure applies to both skilled nursing facilities as well as inpatient rehab facilities. And so it's a broad label. The second measure that was finalized as part of the quality reporting program in fiscal year 2014 IRF PPS is the influenza vaccination coverage among healthcare personnel, which is NQF 0431. There's more information about the final rule at the bottom of this slide if you're interested. In addition to this overview, we do have separate presentations. One presentation about the patient influenza vaccination measure that I'll be giving this afternoon. And then we also have our CDC experts giving the presentation about the vaccination coverage among healthcare personnel. They'll also be speaking this afternoon. So just a broad overview of the patient influenza measure. Again, the measure is called the percent of residents or patients who are assessed and appropriately given the seasonal influenza vaccine. The use of this measure will begin 10/1/2014 and will affect the fiscal year 2017 APU. Data will be collected using the new item set that's been added to the IRF, and that is, again, the version that starts October 1, 2014. Data will be collected on a fiscal year basis, and the CDC defines the influenza vaccination season as starting each year, October 1, and then ending March 31st. So again, we'll be speaking a lot more about that in detail very shortly. In terms of the data collection and the timeframes for the influenza measure for patients, quarter one, which is considered part of the influenza vaccination season, is October 1, 2014 to December 31st, 2014, and the data submission deadline for that is May 15th, 2015. As Charles mentioned earlier, you will obviously be submitting the IRF as part of the payment system, and so you will follow those deadlines related to the PPS, but if you have any corrections that you'd like to make, you do have the May 15th deadline for making corrections in case you needed that. In the future, the quarter one will remain October 1 to December 31st of each year with the May 15th deadline the next calendar year. Quarter two is also during the influenza vaccination season, and that is the time frame of January 1, 2015 to March 31st, 2015. The deadline for any corrections would be August 15th, 2015. And in subsequent years, again, that would be January 1 to March 31st with the August 15th deadline of that year. Quarter three is April 1st to 2015 and to June 30th, 2015, and the due date for corrections would be November 15th. The subsequent years, April 1st to June 30th of each year, will also have the deadline of November 15th of that year. Quarter four will be July 1st to 2015 to September 30th of 2015, and the due date for any corrections would be February 15th, 2016. We're going to spend a lot more time talking about this item later on, but I did want to highlight that even though quarter one and quarter two are certainly within the influenza season, vaccination season, that you will also be submitting data in quarter three and quarter four, because it could be that you have a patient who, let's say, was admitted March 31st, and that patient was discharged, let's say, April 7th, or April 14th, that person was still in the facility in your IRF during the influenza season, and so there is an expectation that the influenza vaccine would be offered to that individual patient. So the data for that person would be submitted in quarter three, but again, that patient was in the IRF during the influenza vaccination season. We'll be going through a lot more examples of this coming up, but just wanted to emphasize that there could be patients in every quarter that you're submitting with the influenza information detailed. Just wanted to highlight that, again, the third and fourth quarters, which consist of April 1st to June 30th and then July 1st to September 30th, technically fall out of this influenza season, but the question obviously, does the IRF have to perform full influenza screening on each patient outside of the influenza vaccination season? And so this again is an example in more detail of inpatient rehabilitation facilities are required to submit full influenza vaccination screening data on the IRF between April 1st and 9/30, which technically you would think would fall outside of the influenza vaccination season. So very specifically, patients admitted before the start of the influenza vaccination season on October 1st, but are discharged during the influenza vaccination season, so that would be October 1 through March 31st, again, they would be in the facility one or more days during the influenza vaccination season, and so the expectation of those patients would be offered the vaccination. Also, at the tail end, which is the example that I gave a few minutes ago, patients might be admitted prior to or on March 31st, which is before the end of the influenza vaccination season, but they wouldn't, let's say, be discharged until after the end of the influenza vaccination season. But again, the person was in the IRF one or more days of the influenza vaccination season. So while IRFs are not required to report this data outside of the influenza vaccination season, except during the above stated scenarios, CMS is not suggesting that any vaccinations would be withheld that might otherwise be during the time period outside of the CDC defined influenza vaccination season. So again, in summary, if the patient was in the facility during the influenza vaccination season, whether it was 1 day or more, the expectation is the patient would be offered the vaccination. Next, I'm moving to the influenza vaccination coverage among healthcare personnel. So this is the NQF measure 0431. Again, you'll be learning a lot more about this measure from the CDC experts this afternoon, but I did want to give you a brief overview and talk about the timeline. So the use of this measure begins October 1, 2014, and will affect fiscal year APU, or fiscal year 2016 APU. This measure includes healthcare personnel working in the IRF for at least 1 day during the CDC-defined influenza vaccination period of October 1 to March 31st. Each IRF will be required to collect data about healthcare personnel that do and do not receive the influenza vaccination during the influenza vaccination season. IRFs will submit one report to CDC through the NHSN during the time period of April 1st and May 15th of each year. You should be familiar with the NHSN because that's the mechanism through which you've been reporting the CAUTI data at this point in time. Just some data submission guidelines to highlight about this measure. So IRFs are required to submit a final report to the NHSN during the time period of April 1st to May 15th of each year. However, CDC and NHSN strongly encourage that healthcare personnel influenza vaccination summary counts be updated on a monthly basis. Data should be reported separately for employees, licensed independent practitioners, and adult students, trainees, and volunteers. Reporting summary data for all other contract personnel is optional at this time. When Megan from CDC presents this afternoon, she'll show you what the actual submission page looks like. So again, the data collection time period for this measure for the upcoming year is October 1, 2014 to March 31st, 2015, and the data submission deadline is May 15th, 2015. In subsequent years, the time frame is the same, October 1 to March 31st, and again, the deadline each year will be the May 15th of that year when the influenza vaccination season ends. In the fiscal year 2014 PPS rules, CMS also adopted a claims-based quality measure. So that claims-based means that they are looking at the bills or the claims that are submitted. And the measure that uses that's claims-based is the all-cause unplanned readmission measure for 30 days post-rehabilitation, post-discharge from inpatient rehab facilities. IRFs are not required to submit any data for this because the information, as I just stated, is from the billings or the claims data submitted to CMS. You'll be learning a lot more about the readmission measures from my colleagues Lori Coots and Mel Ingber this afternoon. There's also quite a bit of information on the CMS website about the specifications, and they have those links in their presentation this afternoon. So I wanted to spend a little bit of time talking about the upcoming changes to the IRF PI. So IRFs are currently using IRF PI version 1.1 to submit payment-related data and pressure ulcer quality data, the IRF PI quality indicator items, to CMS. IRF PI version 1.1 went into effect October 1, 2012, and will remain in effect until September 30th, 2014. On October 1, 2014, IRFs will begin to use the revised IRF PI, which is called version 1.2. IRF PI version 1.2 contains revised pressure ulcer items and the patient influenza vaccination measures that I was just speaking about. In terms of the submission requirement, IRF PIs must be completed for all patients receiving inpatient rehab facilities in an IRF under the following Medicare programs, both the Medicare fee-for-service and Medicare managed care. For more information about the collection and submission of the IRF quality measure data during the IRF PI quality including the IRF PI quality indicator items, please visit the CMS website. The information is right here on the slide, but you can also Google IRF QRP and you'll get there pretty quickly too. The IRF PPS webpage for the payment is also listed on this slide, and that is www.cms.gov/medicare/for/Medicare-fee-for/service-payment/inpatient rehab fac PPS/index HTML. I did want to wrap up this presentation by highlighting the help desks that we have available. So if there are any technical issues regarding the IRF PI submission, the email address that you can use to get help is irftechissues@cms.hhs.gov. Questions regarding access to QUEES, the Irvin submission, and CASPR, you can contact the QUEES Technical Support Office staff at help@qtso.com. They also have a phone number, 1-800-339-9313. Questions regarding the clinical items on the IRF PI that are not the quality indicator items can also be obtained by calling the QUEES Technical Support Office. Again, that is help@qtso.com. And again, the phone number, 1-800-339-9313. We also have resources specifically to the quality reporting program. And so the email address is listed here. It is irf.questions@cms.hhs.gov. And we are monitoring the email today. For those of you who are on the webcast, we'll be happy to take your questions if you submit them through the this email address. We'll be monitoring those and we'll be able to take those questions. We also are happy to take questions here from the live audience. You should have picked up some index cards. So if you can either give those cards with questions to me or Magda, who's sitting up front, we're happy to pass those along to the speakers to address. The website is also up here for the IRF Quality Reporting Program. And there is a mailing that you can get from CMS with regular updates. And so if you're interested in receiving regular updates from CMS about notices about open door forums and training programs like this, the web address is right there. And you can just sign up for whatever program you're interested in. And with that, I will stop, and we are running ahead of time, so that's terrific. And I think we'll check and see if there's any questions that have come in from the program yet, and I'll have Charles come back up here. So the next set of time is for questions, and maybe you want to
switch this. Thank you very much, Ann. Really appreciate it. So we're going to change the agenda here just a little bit. We did have the Q&A session scheduled for 10 to 10:15. We're going to go ahead and let you go on break until 10:15, and at which point we'll pick up with the Q&A session. In the meantime, if any of the folks attending in person have written questions, they can submit right to the table. You can just drop them on the table by the door. And those of you attending via web stream, if you have any questions that you'd like to submit, again, we ask that you submit them through our IRF help desk at irf.questions@cms.hhs.gov. Again, we're going to go on break until 10:15, at which point we'll pick up with the Q&A. Thank you. Hello? Okay, sorry about that. All right, welcome back, everybody. We did have a few questions submitted, so I will go over those questions shortly, and then we will begin with the pressure ulcer session. So one question was, for IRF patients admitted prior to October 1st, 2014, but discharged after October 1st, 2014, should the new version of the IRF PI, which is version 1.2, be used for that submitted case? And the answer is yes. So for any patient that is discharged on or after October 1st, 2014, you will be using the new version of the IRF PI to submit quality data on that patient. Another question regarding the manual: is the IRF PI manual for the new version effective October 1st, 2014 posted? If so, can the address be shared? If not, is there a proposed timeline? So the entire manual, I will say, with the payment information, is not yet posted, and that version will be posted this summer. However, we have posted the Chapter 4, which is the quality reporting chapter of the manual. And that is available at the IRF Quality Reporting website on our training page. So when you go to the main website, you can select training from the upper left-hand corner of that main web page. Click on training, and you can go to the download section at the bottom of the training web page, and you'll find the Chapter 4 of the IRF PI manual there, which is the quality indicator section. And the rest of that manual, as I said, will follow this summer. I would just continue to check the website for that. And these websites will be up again. I'm not going to go over them character by character. It gets confusing, I think, but we will post them again. And the last question is related to IRF PI submissions, asks about slides 15 and 20, and they're referring to the overview presentation that myself and Ann Deutsch gave earlier. They're asking, are these dates for patients admitted or discharged during those time frames? And the answer is they're related to the discharge date, because the IRF PI is submitted based on the discharge date. The admission and discharge information are submitted together. So that's it for now. Again, we encourage you, those viewing through via the internet, through web streaming, to submit questions to our IRF help desk, which is irf.questions@cms.hhs.gov. And then those of you here, please continue to write questions. I know a few of you have submitted questions that I'm going to hold to this afternoon because they're a little more pertinent to that discussion, and we're going to have some presentations that may give you the answers to those questions then. So now we're going to move on to pressure ulcers. We're really lucky today to have with us Elizabeth Aiello, PhD. She is a nurse who specializes in pressure ulcers. She's a faculty member at Excelsior College School of Nursing. She's on the board of directors and the 1999 president of the National Pressure Ulcer Advisory Panel, or the NPUAP. She's chair of the Wound, Ostomy, and Continence Nurses Society accreditation community. And she's a leading expert on the care and prevention of pressure ulcers and other chronic wounds. As a board-certified wound and ostomy nurse, she has firsthand clinical and wound care experience, as well as in-depth knowledge of educational and systems approaches to the prevention and treatment of chronic wounds. In her positions as faculty member at Excelsior College School of Nursing in Albany, New York, and co-director of the University of Toronto's International Interprofessional Wound Care course, she has worked extensively on multidisciplinary approaches to preventing pressure ulcers in hospital settings and reducing risk of amputation in patients with diabetic foot ulcers. So really lucky to have her. She's a great presenter, so I'd like to welcome Elizabeth Aiello.
Well, thank you very much, and I'm really excited to be here. I just want to, we're always evolving in terms of what we do, and I just want to correct a few things that I'm actually on the Alumni Council now for the National Pressure Ulcer Advisory Panel, and I'm also a past chair of the WOCN Accreditation Committee. As you can imagine, I need to let go of certain things so that I have time to do other things. So I'm really excited to be here on May 12th and want to say congratulations to all the nurses around the country. I'm sure you are aware that today is Florence Nightingale's birthday, and it seems hard for me to believe that we are almost 200 years from her birth, since she was born in 1820. So in 6 more years, it'll be the 200th anniversary. And of course, Florence Nightingale was one of the leaders of using evidence for wound care with her work in the Crimean War. And she was one of the people who challenged us to look at processes. When she said if people got pressure ulcers, it was a process that you needed to look at rather than a particular person pointing the finger at any one particular discipline. So, and I also understand this is the beginning of National Hospital Week. So congratulations to all of you who might be tuning in from hospitals to look at that. So I've been given the task of really summarizing some of the information that's out there about pressure ulcers in an hour and a half. So you can imagine this is quite a task to do. So if I leave out your favorite area of pressure ulcers, forgive me now for doing that, because there are some time constraints here. And I really approach this from the point of view that this is a summary and a review of content for people rather than presenting new information. So here's my objectives, which I know that you can read, but I really wanted to focus in on an area which I think causes a lot of confusion, and that is really being able to differentiate the different kinds of skin injuries that occur, particularly what is a pressure ulcer and what is not. I went to nursing school a long, long time ago in a galaxy far, far away to where we are now, where a lot of skin injuries weren't even thought of and communicated. So this is a problem that we're seeing in clinical practice. People are misidentifying things. So I'm going to spend a lot of time up front about what is a pressure ulcer and what is not. So later on, when you hear about coding about pressure ulcers from CMS, you'll at least get the etiology correct. Then I want to talk about pressure ulcer staging in the context of CMS regulations, comparing that to the National Pressure Ulcer or NPOIP staging definitions. So I hope that sounds really exciting for you this particular morning. So I'm going to start out, first of all, with differentiating pressure ulcers from other injuries. And it's always best to start at the beginning so we have common ground about a definition of pressure ulcers. And this is the definition that CMS uses. And as you can see, pressure ulcers are very localized injuries to the skin and the underlying tissue. So you're not going to see them diffuse throughout the whole body. It's conscribed to a particular area. And I have highlighted the words. Any of the on my slides, any of the words you see bolded or underlined are mine. They're not necessarily CMS's. Okay, I do that in terms of pointing out what I think are key pieces of information for people to take. So it's usually over bony prominence, and I think we all know where the bones are located on the body. We know that it's no surprise that the number one area for pressure ulcers is over the sacrum, since most of us sit or lie most of the time in terms of where we are, and certainly patients and residents wherever the care setting the person is. And pressure ulcers are named pressure ulcers because the key etiology is, of course, pressure. And there is a combination in terms of pressure with the mechanical force of shear, or shear force or shear strain, and you'll hear both of those adjectives used after pressure. And CMS does include the word friction in the definition, and I'm going to go into a little bit more about that in a moment. Now, this is my pictorial. I'm a visual learner. And for those of you who are out there, this is to appeal to your learning style. And of course, those of you who are involved in very high science types of research might say, Elizabeth, this is an oversimplification of what we think is going on in terms of etiology of pressure ulcers. So I want to apologize to people who want more complicated, and I'm not trying to make this simplify this too much, but I think that when it comes to skin injuries, you can never make things too simple in terms of the representation. So this is a diagram, as you can see here, of the skin that is available from the National Pressure Ulcer Advisory Panel on their website for educational uses. So you see the different layers of the skin, the epidermis. I think I can get this. Okay, the epidermis, the dermis, adipose tissue. We have different amounts depending upon what our MBI is. So some of us have more of this than others in certain body locations, and you can identify that on yourself and the patients that you see, muscle and bones. So as I said, the primary indication is pressure. And I put the arrow in this direction for pressure because more and more the experts, and again, this is clinical expertise, clinical opinion, are looking that pressure ulcers are a result of pressure that's coming from deep within the tissues outward. So that's why the arrow is in this direction. And then shearing force causing a strain internally within these tissues. And the engineers like to use the term of tissue deformation, which means that the tissues deep within the skin structure are deformed. I almost like to think of this as almost the earthquake of the skin. You have shear force that's coming on the top. You have the pressure deep within the tissue, so it causes this kind of a lateral shift, if you will, of the tissues deep within the area. And that may or may not from a geology point of view, but I get it when I use that analogy for teaching people. Now, friction, as you can see here, is a surface type of a force. So if you think of this as a rubbing kind of a force, rather than a deformation of the tissue deep within, and it causes confusion for people, the word friction, because lots and lots of skin injuries can occur from friction. Now, the reason why I believe the CMS has kept friction in the definition is because if you read the NPUAP position paper about friction and how people have confused friction as a etiological reason for pressure ulcers, is that when you have friction, you need less pressure to have a pressure ulcer occur. So while friction may not be part of the direct etiology, the fact that if you want to use the words, and this is Elizabeth Aiello's words, okay, as a risk factor for people for developing a pressure ulcer, when friction exists, less internal pressure is needed to deform those internal structures within the skin. And that's why you'll see some definitions have friction in the definition and some do not. Okay, so think of it as a risk factor as you will. Now, moisture is another tricky area in terms of what's going on with the skin. And I'm going to talk a lot about moisture in a few minutes, but again, once you have moisture on the skin, we believe at this point that less pressure is needed to cause a pressure ulcer. And there's other skin injuries, which I'm going to identify, can certainly happen from moisture. But it sets up a series, if you will, of a deck of cards in terms of things that can go wrong with the skin if you have moisture available. So the problem is that people start to identify skin problems that are basically the only etiology that's there is moisture or friction as pressure ulcers. And for many years, they were misidentifying these skin injuries as pressure ulcers when they are not. So that's really important on Earth Pie, that you get that etiology correct in the pressure ulcer section that you will be hearing about the coding later on. So I want to emphasize that it's not easy to get the etiology correct. And that's a really important take-home message for people to remember. I think that I'm almost doing this talk in reverse. I'm showing you pictures of skin injuries later on, and for those of you who are non-clinical watching this, I want to apologize for all the gory photos that I'm going to show. I'm going to be showing lots of rear ends, so I don't want anybody to be offended by seeing people's bottoms. But, since sacrum is the #1 place for pressure ulcers, it's a little hard to do a lecture on pressure ulcers without showing people's rear ends. So please take no offense from them. So I've alluded to superficial skin changes as being really a lot of them from friction or moisture, as opposed to this deep tissue framework of internal pressure and tissue deformation, as well as some reperfusion injuries, which I haven't really spoken about yet. But that is part of the underlying pathophysiology that the experts are telling us are probably what accounts for pressure ulcers. So another thing I want you to remember is pressure ulcers are not so cut and dry in terms of the etiology. They are multifactorial. Internal tissue deformation, as well as something going on with the blood flow internally in that tissue, and whether it's when the blood flow is turned off to the tissue and then opens up and we have release of free radicals that causes the damage, or if it's the pressure that causes that earthquake, if you will, deep inside the tissue. We're still trying to understand that, but it's important to get this right. So I based this on an article that was published that actually caused a lot of controversy out there in the wound care world by Sybil and al., which was published in 2011. And while I don't want to get into the controversy here, I thought it really was helpful in terms of separating out superficial skin injuries in a different way for people to look at versus deeper. So when you look at types of tissue injury, certainly stage 1 and stage 2 are superficial by definition. You're involved either with an intact epidermis or an epidermis that has been lost and into the upper layers of the dermis for pressure ulcers. But lots of other skin injuries, for example, skin tears. And I'll talk about that in a little bit more detail. These are acute wounds, not necessarily chronic wounds, although they can become chronic wounds, where the epidermis is separated from the dermis. Or you can have moisture-associated skin damage. And the one that I want to talk about the most has to do with incontinence-associated skin damage as an etiology, but I will review the 4 different types of moisture-associated skin damage and give you some of the current thinking of the etiology of this skin injury. Contact dermatitis I'm really not going to talk about in great detail, but obviously anything that our skin can react to that can cause an inflammatory process can also be a superficial skin injury. And then friction blisters. Remember, again, rubbing can cause blisters. Now, deep within the tissue, that's where the stage 3 and 4 pressure ulcers, as well as unstageable pressure ulcers, can happen. And I'll talk in great detail about those staging definitions later on. Okay, so what I've tried to do in the next series of slides is to give you a very quick summary of elements that you might use for training within your facilities to help people to identify some of the key characteristics of getting the etiology right. By no means are these all encompassing, because the idea of an enabler or a chart is to give people summary key points here. So first I went to things that might be on the lower end of the body, certainly pressure ulcers, sacrum #1, and #2, the heels, okay? And what could be confused with those two areas? Well, certainly your peripheral vascular ulcers, which can be either venous or arterial in nature. So with pressure ulcers, the primary cause is pressure. Remember, when shear is in concert with the pressure, it lowers the amount of pressure that is then needed for that deformation of that internal tissue. As you can see here, and I've said, and I will repeat, because the one thing I've learned in education is tell them, because, you know, our mind goes on little commercial breaks every once in a while, and I think you only hear about 20% of what I say, so I do repeat a lot of things. Over the bony prominences, and the shape of the wound is important. You will tend to see it more oval in shape over those bony prominences area. And I've included a nice necrotic, not so nice for the patient, but a very classic photo of somebody with a necrotic pressure ulcer on the heel. Now, venous, the human being needs to have venous disease. Now, that would seem obvious. So those who can identify a medical diagnosis would need to do that. And that's going to vary by state to state in terms of who can do that. Certainly physicians assistants, and in some states advanced practice nurses such as nurse practitioners can make those kinds of determinations. And usually there's some kind of trauma that precipitates the occurrence of a venous ulcer in somebody with venous disease or some kind of infection in the leg for the person. Classically, as in real estate, it's all about location. So venous ulcers tend to be in the lower leg area, around the ankle or just above it in the lower third of the calf. And I'm probably really dating myself when I say gaiter area, because most people nowadays don't know where the gaiter area is. So that's right above the ankle. If you remember years ago when people wore spats on their above their shoes to prevent dirt getting into the lower part of their pants leg, that's about where you would find venous ulcers. And you have this serpiginous type of a margin, so it's not exactly even. It's irregular, the margin of the venous ulcers. You will also see, as you can see here, you notice the brown discoloration, and this is true of anybody. It doesn't matter what your skin tone is. You will see this staining that typically is with somebody with venous disease. As the red blood cells leach out into the surrounding tissue, you get that brownish discoloration. In fact, the intensity of the brownness can be used as one of the markers for long-standing venous disease in the person that you see. So this requires a total treatment of the person, not just the wound, but the venous disease as an underlying disease. Now, arterial is about the arteries. So what's happening here is you have inadequate arterial blood flow, or ischemia, if you will. And again, trauma and infection can precipitate arterial ulcers, and you need the whole team here. It's not just about the local wound care. You must treat the problem. If blood flow is not getting to the area, you are not going to heal that ulcer. You have to have the flow of blood. Typically, what you'll see, as you see in the picture below, is this gangrene, usually down on the toes. And these ulcers tend to be very punched out in their appearance, very fibrinous, and again, look for trauma and infection in these particular persons. So now I wanted to look at pressure ulcers. Now, you saw this photo just on the last table. So you saw that again. I blew it up to show you some of the differences and discuss between pressure ulcers versus diabetic neuropathic ulcers. Now, when you come to the foot, it can be tricky to differentiate what's a pressure ulcer and what's a diabetic foot ulcer. And it may sound obvious, but to have a diabetic or a neuropathic foot ulcer, you must have diabetes. Now, remember that there are many people out there that have undiagnosed diabetes, so that once somebody starts developing an ulcer down on the lower foot, and you think that it might be from diabetes, you might need to do some testing to find out if the person has diabetes or not. And then second of all, CMS says that somebody with diabetes can certainly get a pressure ulcer. So again, the etiology is really important. If pressure is the primary etiology, according to CMS, then it is a pressure ulcer. So that even somebody with diabetes who gets a ulcer on the heel, that could be coded as a pressure ulcer. And I suppose you'll hear more from CMS about that later on in how to code. Now, when it comes to diabetic foot ulcers, as you can see, many times you will see them up on the head of the metatarsals, as you see here, or the plantar area of the foot. And you see this callus area. This is very, very, very typical of diabetic and neuropathic ulcers. You don't tend to see that in pressure ulcers. So that can be one of the key areas that you might look at in terms of identifying a clinical sighting that you could see that will help you to say, is this a pressure ulcer versus a diabetic? And remember, these are not absolutes, but these are what I call wound guideposts to help you in terms of differentiating. And this is where the team comes into play. I think that it's really important sometimes, if you're not sure what you're looking at, to gather the team together, the interdisciplinary team, and say, okay, what are we looking at? Because it's not so easy to get this right. Okay, some other skin areas that can be misidentified as pressure ulcers, and there's been a lot in the literature over the last 3 years to help people to understand the differences here. I think I've kind of given you a good perspective about pressure ulcers, I hope, and I want to concentrate on skin tears and moisture-associated skin damage, or as you see abbreviated here on the table, MASD, M-A-S-D. So skin tears are from trauma. They can also be from friction of the skin. You typically see this on the arms and the legs, or any areas where you might have tape or any kind of adherent type of product on the skin that when you remove it, you literally are tearing off the epidermis of the skin. Typically, in older persons, you may see it over areas of senile purpura, as you see here, where you have the area of senile purpura, and you have the skin tear right over here from removal of a tape, for example, or just transfer. Can be another underlying etiology that skin tears happen to occur. Moisture-associated skin damage, the current thinking is, and this is why they're called moisture-associated skin damage, is moisture is the problem, as well as, again, friction. And you tend to see this in areas where moisture is most often found, and that is in the buttocks area. Remember, the buttocks is the soft tissue on your rear end. The sacrum is the area of the skin over the bony prominence. So don't mix up buttocks and sacrum. They are two anatomical different areas in terms of where you might see a skin injury. That doesn't mean that you can't have a pressure ulcer that is so extensive that it extends over the soft tissue, but it will most likely start over the bony prominence, which is either the sacral area or the ischial tuberosities, for example, or the coccyx, which is the tip of the sacral bone. So moisture-associated skin damage, you're going to see this over the perineal area. It's much more diffuse, for example, than a pressure ulcer, which, remember, is a localized area of skin injury, and of course you can find it in skin folds as well. Now, skin tears, as I said, is a relatively new area that people are trying to wrap their hands around, even though the literature goes back well into the 1980s and 1990s when we started to see some information out there, and there actually was a risk assessment scale published in the 1990s on skin tears. It's not well known. It's not well used. And skin care classification systems, the original one by Payne Martin in 1991, again, not well known, not well used, and then people started misusing the NPOIP staging system to classify skin tears. Second important thing, do not stage skin tears using the NPOIP staging system. There are classifications for skin tears. In fact, there's been a recent initiative, as you can see here from the citations from the literature, that has really been led by Kim LeBlanc from Canada and Sharon Baranowski from the United States, and an international team to really quantify and review the literature for what we know about skin tears. And I've included the website, www.woundcarejournal.com, and many of their articles on skin tears are available for free download for you to read about. And they have proposed a new classification for skin tears, really simplifying it to basically, is just a slit in the skin tear flap, is part of the skin tear flap gone, or is the whole skin tear flap gone? So that there's really three categories. And again, that is an oversimplification of that classification system there. So you can read about that. As far as I know, this is not yet on IRF, but again, to get the etiology correct. One of the areas that I think people misidentify the skin injury happens to be on the buttock area. So here's some of the clinical pictures that I promised you down in the sacral and the buttocks area. So again, you can see how much more diffuse skin injury from moisture is as opposed to pressure ulcers that are much more localized. And here's another example. So here's where the sacrum and the coccyx would be, and you see this is much more extensive onto the soft tissue. And you can also see these satellite areas that are around moisture-associated skin damage. You don't tend to see those with pressure ulcers. So again, those are some of the clinical guidelines or guideposts, if you will. They're not really guidelines, what I call clinical indicators that would help you to differentiate what am I looking at other than a rear end of the human being in terms of classifying the etiology. So here's a little chart which I put together with my doctor colleague, Dr. Sybil from Canada, which we use for teaching people about some of the differences about the different kinds of moisture-associated skin damage. And I've highlighted the word damage in terms of, what's wrong with the skin here. The skin has been damaged. And here's the, right now, one of the accepted definitions of out there in the literature, that there's some kind of inflammation and erosion into the skin that's caused by prolonged exposure to various sources of moisture. So I think most of us think immediately about urine or stool, particularly from somebody who's incontinent. But there's other sources of moisture that we may not have thought about, such as perspiration. And you think about here in America, for example, we are moving towards higher and higher BMIs. Our body mass index is very high compared to other areas of the world. At least we're only number 2 now in terms of nations of the world, in terms of people that are on that end of the spectrum. Perspiration, when skin to skin is in contact with each other, moisture can be trapped, for example. So anytime you have skin folds touching other skin folds, if somebody has a wound and exudate is coming from the wound, that can damage the skin and the surrounding that particular wound. You can have mucus. For example, let's say somebody has a trach and you have damage of the surrounding tissue from mucus or saliva, somebody who's drooling, for example. So lots of things can cause damage. It's not just urine or stool, although that is probably the most frequent one that we see here. So damage, think damage from moisture or these other areas. And then there are 4 right now etiologies. Intratriginous dermatitis is from perspiration. So think about people with higher BMIs, for example, that when you have pannus, where the skin fold is touching, or large breast, for example, or the back of the neck, the back of the knees, or any place you have skin-to-skin fold, think about intertriginous dermatitis as the etiology for moisture-associated skin damage. The other is incontinence-associated skin damage from urine or stool. And some of the thinking behind this that has been published out there in the literature by Michael Gray and colleagues in the Wound Ostomy Incontinence Society Journal in 2011, where they had a good series of articles that you might want to take a look at, has to do with a little rethinking. It's not just the moisture, although that's part of it, but it's what's in that moisture. Now, if you remember way back when you all took anatomy and physiology, I think most of us learned that the skin has an acid mantle to it. Well, what happens when you have urine and feces, remember that the pH in urine and feces can be alkaline. So as you raise the pH on the skin from that normal acid mantle to pH in the alkaline range because of incontinence, what happens? What happens is bacteria will start to proliferate in an alkaline environment, whereas our normal acid mantle keeps down the growth of bacteria. So whether it's a combination of a shift in the pH to a more alkaline area, plus this wetness on the skin, we're not sure if it's the combination of the two or exactly how this interacts, but this is new thinking that I've learned in terms of what might be going on with moisture-associated skin damage. The P's are for peri-wound moisture-associated skin damage. If you have a wound that's leaking a lot of fluid, certainly you can damage the skin. And if somebody has an ostomy, as you see down there in the corner, peristomal moisture-associated skin damage, so you have to have an ostomy. So I'm not going to deal with those two, but really I'm interested in the incontinence-associated skin damage. Now, human beings come in a variety of skin tones. And from some research that I've been involved with in the Philippines, this has become acutely aware because one of the things to identify skin injury from moisture-associated skin damage, most of the scales out there really deal only with white skin and deal with redness. And as we all know, this is not translatable to the diversity of cultures out there. So this is a teaching tool which Dr. Sybil and myself actually created as a research project to help people take the Kennedy Skin Assessment Scale and make it applicable for people with brown pigmented skin using the Fitzpatrick level 5 for those of you who use the dermatology Fitzpatrick scale for identifying skin tones. And we have given people free access to this, so if this would be helpful in your institution, you can just go to www.woundpedia.com and you can download this to use this to rank the degree of severity of the redness in people within the brown pigmentation scale. So when you're trying to differentiate, when I'm looking at somebody's rear end, is this moisture-associated skin damage or is this pressure? This is a quick and highlighted enabler that you can use. Remember, it does not encompass everything that you need to know about pressure versus moisture, but it summarizes the key areas. So typically with moisture-associated skin damage, you have to have moisture, all right? Whereas pressure ulcers, it's pressure. It's usually localized, whereas with moisture it's more diffuse and you get those satellite areas as you saw earlier, as I pointed out. The edges are much more irregular in moisture-associated skin damage, whereas in pressure ulcer they're fairly distinct. You can see the sharpness of the edges around the pressure ulcer. The color may be an indicator, again, depending upon the person's normal skin color. Right now, the current thinking is that in pressure ulcer, it's non-blanchable erythema, whereas in moisture-associated skin damage, it is considered blanchable. That may change in the future as we have more research, but right now that is the current consensus of what we believe to be true. And by the way, everything I say is true as of today, May 12th. It may change in the future as new research comes out this evening, for example. So, it's true as of today. Moisture-associated skin damage is typically superficial, whereas pressure ulcers can be superficial and obviously can be full thickness, such as in stage 3, 4s, and unstageable. Typically, you do not see necrosis in moisture-associated skin damage. Once you see necrotic tissue, it tends to indicate that you have probably converted a moisture-associated skin damage into a pressure ulcer, because remember, less pressure is now needed to cause a pressure-induced injury when you have moisture, okay? And there, on the bottom of that slide, you can see some really good references from the literature that go into much more detail than I have said in the few minutes that I've been talking about this. And I would really refer you to them, particularly in your agencies as you're looking for policies and procedures and much more detail on this area. So hopefully I have given you some new ideas, one new idea in terms of differentiating pressure ulcers from other skin injuries. So when you look at this, and as I said earlier, this is not so easy. You need to take a look at the history of what's going on with the human being, what's gone on with them. Have they recently been transferred, for example, from a wheelchair to a different surface, that the skin maybe got sliced off and this is a traumatic injury, or has somebody been sitting in a long time without pressure redistributing cushion in the area? What's the role of moisture? Again, pressure ulcer to be there primarily related to pressure. Need to rule out some of the contributing factors that could indicate an original skin etiology that then transferred to, let's say, moisture. Okay, because something could start out as a moisture-associated skin damage, but if that's not adequately prevented or treated, it can convert to a pressure ulcer. Certainly identifying whether this is vascular in nature, arterial or venous, what was the role of friction in trauma areas. So, you don't want to rule those out so that you're really identifying somebody as a pressure ulcer if it truly is a pressure ulcer. So CMS, in its manual, in many care areas, not just in rehab setting, has said that it's got to have primarily related to pressure, that you need to rule out all these other conditions for it to be identified as a pressure ulcer. So once you do those, history, for example, now if somebody already has a pressure ulcer, that could be a good clue that what the other etiologies that you're seeing might be related to pressure ulcer. And all these conditions, that's when you're going to use the staging system that has been identified and used out there for staging the pressure ulcer. I wanted to give you some data that's out there in the literature. Obviously, CMS has other data, but this is out there for general access. And this is some research that was published in 2009 by Van Gilder and al. They looked at pressure ulcer prevalence in different care settings, acute care, long-term care, LTACs, and rehabilitation setting. Now, one of the delimitations of this is that they did not identify what they meant by rehabilitation. So I leave that to your interpretation in terms of whether these are inpatient units or other kinds of rehab settings. But I thought the numbers were interesting enough to at least give that to you for some food for thought for you to look at. And you can see the numbers over the years have gone up in terms of those who have participated in this voluntary data self-reporting from it. And overall prevalences, that means it doesn't matter where that pressure ulcer occurred. Remember, prevalence includes anybody who arrives at the rehab setting with a pressure ulcer or anybody that acquires the pressure ulcer in the rehab setting, as opposed to FA, which is facility acquired. Now, some people use the term facility-acquired prevalence to be synonymous with incidence, and that's what these particular people are using it to mean. Somebody who developed the pressure ulcer in the facility. And so you can see that it, except for 2008, where it spiked to 6.6%, it's been around 4% across the rehab settings. Now, one of the issues has to do with stage 1 pressure ulcers. And I'll tell you that's probably one of the stages that most people misidentify what's a pressure ulcer from a friction injury because of the superficial nature. And that is why some people identify their statistics excluding stage 1 pressure ulcers. So again, you will see the numbers are lower here in terms of overall prevalence, ranging from 10.4 to 14.6. And for facility acquired, when they exclude the stage 1s, you can see there in the 2s, the spike in the 4s in 2008 when you had higher numbers, and then the 3.1 for 2009. Okay, so having given you that background area, I'm now going to talk about the big area, which is how do you stage pressure ulcers? And I will say in one word when people ask me, Elizabeth, how do you stage pressure ulcers? I will say carefully. That you have to have a combination of the content knowledge here, but the ability to know what you're looking at when you see the ulcer or the wound in front of you. So it is a skill that I believe is learned over time. That when you first start out in practice, your ability to get the stage right is not going to be as accurate as with experience. And again, I believe that we need to think more about a team approach in terms of, what are we looking at? Get that etiology right and get that stage right. So here's those diagrams that I talked about earlier in terms of pressure ulcer staging from the National Pressure Ulcer Advisory Panel, going through the 6 stages of the diagram, going from very superficial injuries from stage 1, where we just have an intact epidermis, to stage 2, where the epidermis is now open, to stage 3 and stage 4, we are deeper into the subcutaneous tissue, into unstageables and suspected deep tissue injuries. Now, CMS, and this is not a typo, and again, I have color-coded and underlined this, has adapted but not adopted the NPOAP staging definitions. And they're using the 2007 staging definitions. So while NPOAP has 6 distinct stages in the United States. By the way, in Europe, there are only 4. So in the US, NPOAP has 6. For CMS purposes, there are 5 distinct categories: stage 1, 2, 3, and 4, and then unstageable. And under unstageable, there are 3 subcategories that are possible, depending upon, if you will, the characteristics or the etiology. So there's a difference in terms of the staging definitions. And as I like to say to people, when you are filling out CMS forms, you need to use the higher authority, and that is CMS, in terms of how you will use those definitions. So you need to use that for completing the forms, which you're going to hear about later on in terms of how to code on IRF. Now, in the NPOAP clinical guidelines, which, by the way, you can download from their website, which is www.npoap.org, They have as one of the statements here that you need to confirm the reliability of classifications among professionals responsible for classifying pressure ulcers. And that's where I've said it's not so easy. People don't always get this correct. And I've actually done some research, and if you want to read, at least from a nurse's point of view, in the April issue of Nursing 2014, we, meaning myself and Sharon Baranowski, have reported some interesting data about nurses' ability to stage pressure ulcers. And we found it very interesting that when nurses self-reported, these are nurses across the United States, self-reported their ability to identify pressure ulcers by the correct stage, only 55% said that they could do it accurately. And this is down from 70% who said they could do it accurately when we first asked them in 2008 in a survey. So this is really, I'm really grateful for CMS for giving me the opportunity to talk about staging, because I really think that as much as people hear this kind of information, it is a complex skill for people to do, and it's almost like you can never hear it enough. So I thought we would start out with a little quiz in terms of true or false. So if you want to write down your answers before I reveal the answers, and I won't know what to write down. So, is an ulcer on the mucosa from a medical device, should it be staged? So just put down a little T or an F for you. Pressure ulcer staging is based on the depth in centimeters. You can write either true or false. As the ulcer heals, you should reverse or backstage the ulcer. So you would go from, let's say, a 4 to a 3 to 2 to a 1. How about staging a pressure ulcer requires clinical skills, including minimally observation and palpation? Do you think that's true or false? And the CMS definition of stage 2 pressure ulcer differs from the National Pressure Ulcer Advisory Panel. Do you think that's true or false? So would you like the answers? Well, here they are. The first 3 are false, and I'm going to go over them in a little bit of detail so that you have the facts as to why. And the last 2 are true in terms of how you would stage, and I'll go over the differences between stage 2 pressure ulcers from a CMS perspective for you. Now, for those of you who are watching at a distance, my understanding is that the slide deck that is posted has all the answers to the questions at the end of the, this way you couldn't cheat and look right as we're doing this live here. So, pressure ulcer staging is based on a comprehensive view of the human being that you're looking at the wound. So what is the history? What are the comorbidities? What is the situation that the person is in? So you don't do this in isolation of just looking at the wound. So what are the factors that are going on with the human being? And that you need to actually look at the wound. And this includes, at a minimum, a visual inspection of the wound, observation, and another part which people sometimes forget, and that is palpation. And particularly when we get to stage, differentiating between stage 3s and stage 4s, people sometimes forget the ability to palpate, because you want to be looking for a bone with a 4 versus a 3. That you need to look at the full body of the person from head to toe. Even though the key areas for pressure ulcers are on the sacrum and the heels, you can get pressure ulcers in other body parts depending upon what's going on with the human being. For example, if they have a brace on, they can get a pressure ulcer underneath. If somebody's very bony, a bony prominence is on the spine, for example. If you think of somebody who's very thin, on the other spectrum of the BMI continuum. So think about any area of the body that is prone to pressure. So if somebody's laying down, think of all the bones that are in contact with the surface. If somebody is digging their elbows, for example, into the mattress, then be thinking of a pressure ulcer over the elbows. Or somebody who's spastic and moving their heel back and forth on the sheet. You could have a friction injury that turns into a pressure ulcer, for example. You need to clean the ulcer before you do the staging. And the reason you want to do this is you want to make sure that you're not staging a pressure ulcer as a higher stage, because there still is some of the dressing, for example, with hydrocolloids or alginates, where you have an interaction of the wound with the wound fluid, and it could look like slough, but it isn't slough. So if you don't clean the wound to get rid of the dressing part first, you might be upstaging it to a higher stage than it really is. So clean the ulcer first. And you are staging the pressure ulcer based on the type of tissue that you identify in the pressure ulcer, not the depth, not how deep the pressure ulcer is. And this is really important. So it's not the centimeters, it's what am I looking at? What kind of tissue am I looking at that helps me to identify the stage of the pressure ulcer? So that's why that answer was false originally on my little quiz. So for those of us who need a reminder about tissue types, this is just a visual looking at some of the photos from a colleague of mine in terms of what tissue we're looking at. And regardless of your skin tone, new epithelial tissue is going to look fairly pinkish and shiny in its presentation. Granular tissue is mostly red and kind of cobblestone looking. Depending upon what's going on with the person, it might be friable and it might bleed very easily. And that might signal other problems that are going on in terms of infection that might indicate very friable bleeding granulation tissue. Slough tissue is usually yellow in color, and it can be different colors also, but typically it tends to be yellow, it tends to be moist, it tends to be stringy. I hate to use this in case anybody's anticipating to have this for lunch, but if you think of the mozzarella cheese on the pizza as being stringy, that's a good analogy for slough. Whereas eschar tends to be rather hard. It's black, brownish in color. And as you can see here, this is a person with hard, dark black eschar with some slough around the area, and this is kind of lifting off from this particular pressure ulcer. All right, so here's some of the definitions. I'm just going to go over the key points for you. Again, this is non-viable tissue. It's not going to heal. Yellow, tan, gray, brown, or black. It's usually moist. It's stringy. It can be adherent, and it can present as cloughs throughout the wound. This one obviously is totally covering this particular wound. Here's eschar in terms of dead or devitalized tissue, and as you can see, it can be a variety of colors. The other thing is that sometimes to people, they confuse eschar with a scab. And if you remember way, 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 way back when we had what our mothers called, and yesterday was Mother's Day, so thank you, Ma, for taking care of all our boo-boos, but we have evolved now. Scabs are not the same as eschar. All right, different things. So eschar is dead tissue. Tissue is dead. It's not going to resurrect into a healing wound. It's got to go. The eschar must go. All right, and you can see here that it's usually fairly adherent to the base of the wound and often starts to lift up from the sides of the wound. As you can see here, it's lifting up in this particular area. Okay, so one of the questions that I'm asked a lot is, how much of the dead tissue, either the eschar or the slough, makes it unstageable? And my quick answer is, it depends. It depends, okay? And I know people want a definitive percentage from me, and the answer is I can't give you a definitive area. So I use the word partially covered. If you can see enough of the wound bed that you can either visualize how deep the tissue is impacted for that pressure ulcer, or you can palpate the structures underneath, then you could give it a numerical stage, the pressure ulcer. But if the wound bed, as the pressure ulcer as you see down below, which you've seen that picture before, where the wound bed is completely covered with eschar, then that's the pressure ulcer that you're going to identify as unstageable. Okay? And remember, unstageables are not considered worsening from the CMS perspective when they talk to you later on about coding. If you initially code it as unstageable, and once it has been debrided, and then you can identify it numerically, that is not considered going from unstageable to a number as worsening. And I suspect they'll talk more about those definitions later on. Okay, so you saw this. This is for those of you who might have been having a little commercial to talk about some of the staging. So here's the NPUAP definition that is out there, stage 1, and they use the words categories or stages. Intact skin, non-blanchable erythema over a localized area. There's discoloration of the skin, warmth, edema, hardness, or pain. Darkly pigmented skin may not have visible blanching. And they go on to further descriptors such as pain, firmer, warmer, softer, cooler. Difficult to detect in persons with darkly pigmented skin, probably because we haven't been taught this. Okay, and we only rely on color as an indicator rather than comprehensive indicators. Here's the CMS definition. What I did is I covered up the words in the NPUAP definition so you could see the changes in there. So it's intact skin, non-blanchable redness of a localized area, usually over bony prominence. Darkly pigmented skin may not have visible blanching. Darker skin tones, and may appear with persistent blue or purple hues. So what's the difference between blanchable versus non-blanchable? It's the ability to assess by depressing firmly the skin on the reddened tissue and then releasing it. So if you depress down on the skin, if the skin color pales, and again, paling is going to be different depending upon the spectrum of skin color that the person has. If it pales or changes color, that's considered blanchable. Okay, so it's not a pressure ulcer. If it's non-blanchable, if there's no loss of skin color, it doesn't get pale or what we call pressure-induced pallor at the site, we call that non-blanchable, and that would then be classified as a pressure ulcer. So I hope that slide is helpful for clinicians out there in terms of differentiating the terms blanchable versus non-blanchable. So some key points for detecting stage 1 pressure ulcers. Obviously, you need to be able to see the skin. So you need adequate light. You know, some rooms are very dark. It's hard to see. There are even people that sell little lights that people can put on their foreheads to help assess at the clinical bedside. Flashlights. I mean, Florence walked around with a little lamp. That was so that she could see what was going on. So having the ability to assess the skin with adequate determination of the color is important. And then not relying on just color as one descriptor, particularly with stage 1 or deep tissue injury, which is what DTI stands for. So besides color, you might take a look at skin temperature. And where the literature out there is telling us more and more and more about the role of skin temperature, and it's beyond the time limit that they've given me, but certainly you can look at some of the work that's out there in terms of the role of skin temperature and pressure ulcers that are out there. Here's the stage 2 definition, which again is superficial. Stage 1 and 2, superficial. Partial thickness loss of the dermis, presents as a shallow open ulcer. And the key word here is no slough. So there's no dead tissue. Once you have slough, you are beyond a 2. It may present as an open or intact ruptured serum-filled or serosanguinous-filled blister. And again, don't use this to differentiate skin tears, tape burns, incontinence-associated dermatitis, moisture-associated skin damage, and the other kinds of wounds that I was talking about. So here's the CMS definition. And again, I've taken out what was to show you the difference. Again, partial thickness, shallow, open, without slough. So there's consistency here, CMS, no slough in a stage 2. It may also present as intact or an open ruptured blister. Notice the color of the fluid is not part of the definition from CMS. So there's no slough, there's no bruising, and again, they tell you, make sure that you're not confusing this with moisture-associated skin damage, tape burn, skin tears, or whatever, which is why I spent time on that. So when you look at stage 2 pressure ulcers, and this, for those with really good eyes, you see here this yellowish stuff here? This is an example of somebody who was trying to stage the pressure ulcer before they cleaned the pressure ulcer. So that was part of a hydrocolloid dressing that was on the wound. So unless you cleaned it, you might not have realized that this was really a stage 2. If you thought that that yellowish stuff on the wound was slough, you would have staged it higher as a stage 3 because, right, there's no slough. So again, another reason why you always clean the wound before you stage it. So you look at the skin, shiny areas of tissue loss, don't use it to stage the skin tears, no slough. And if there is a blister, and you think it's from a pressure ulcer, you need to examine the tissue around that blister for any signs of deeper tissue injury, which could be from changes of consistency of the tissue, such as softer, boggier, harder, warmth, or tissue color. Okay, and if you find any of these characteristics, they may suggest deeper tissue injury rather than a stage 2 pressure ulcer. I think I have a few more minutes before we're breaking, so let me just go over stage 3, and then we'll stop and have lunch most likely. Stage 3, now we're into full thickness tissue loss. We are into the subcutaneous fat, but not into bone, tendon, or muscle. They are not exposed. They are not palpable. Okay? You can have some slough, but you don't have too much that you can't see the wound bed, and I've already told you it depends on how much is too much. I can't quantify that for you. And you can have undermining and tunneling. Remember that on certain body parts, such as over the nose, the ear, over the ankle, you don't have a lot of fat or adipose tissue. So these could be fairly shallow wounds, but you can be down into other structures that would make them a stage 3 because you are into a deeper type of tissue. So remember, it's bone and tendon not visible or directly palpable. And in the stage 3 definition, it's basically about the same. CMS is fairly consistent with the NPOP definition. It's full thickness. You have subcutaneous fat, may be visible, but no bone, tendon, or muscle exposed. Slough can be present, but doesn't obscure the depth of the tissue. You can have undermining and tunneling. The depth varies depending upon where it is, such as on the nose, the ear, the occipital, and on the ankle. So it may not necessarily be deep, but you don't have bone, tendon, muscle visible or directly palpable. I'm going to do 4 because I think we have about a minute left. Just to contrast it, the big difference is you have exposed bone, tendon, muscle. You can have some eschar or slough present, but it's not enough that you can't see. And once again, it doesn't necessarily have to be deep. In the areas over that we've identified, such as the nose, ear, or the ankle, they can be fairly shallow, but you're into those tissues such as bone, tendon, or muscle. And same thing with the CMS definition, exposed bone, tendon, muscle. On some parts of the wound bed, you can have slough and eschar. And again, on the coding tips, it tells you that it can vary by the anatomical location, such as on the nose, the ear, the occiput, and the malleolus. So they can look fairly shallow, but remember, staging is by tissue type, what you see or what you can palpate. So I think this brings us exactly to 11:30, and Charles Padgett, I don't know if you want to make a comment before we break for lunch.
Thank you very much, Elizabeth. So we are going to break for lunch now, and we're going to ask that you be back here by 12:30. But before we break, I just want to make sure, is there anybody that did not receive copies of the presentations that needed them? Okay. All right. So again, if you have any questions, you can drop them right at the table where I'm sitting over here on your way out to lunch. You could drop them when you get back from lunch. But we will convene back here at 12:30 and continue Elizabeth's pressure ulcer presentation. Thank you.